Hello everyone, I am Dr. Tamoghna Jana from Department of Oral and Maxillofacial Surgery, Sri Balaji Dental College and Hospital, Chennai. Today we shall be discussing on the topic of mandibular fracture and its management. So before we delve into the deeper layers of mandibular fracture and its management, we should first reiterate our known knowledge about the basic anatomy of the mandible and also its development. So, the mandible came from the Latin word mandibula, that is jawbone. It was also previously known as the inferior maxillary bone. It is the largest, strongest, and lowest bone in the face. It forms the lower jaw and holds a tooth in place. It is also the only movable bone in the craniofacial skeleton. It comprises of various parts which are the symphysis, body, ramus, angle, condylar process and coronoid process. As you can see in the pictorial representation of the mandible, the various parts, the ramus, the body, the mental tuberance, the mental foramen through which the mental nerves and vessels pass through, the alveolar process which holds the dentition in place, the submandibular and the sublingual fossa, the coronoid process and the condylar process. Here you can see the inner surface of the mandible in a more clearer picture, and we can understand the various structures that the mandible has. First we can see the mandibular condyle. Just below it there is the mandibular foramen through which the mandibular nerves and vessels pass through and innervate and supply the mandible. Then below it is the mesenteric tuberosity, and below that is the gonian angle. In the central portion there is the mental spines, which are also known as the genial tubercles, and they give rise to the attachment of various muscles such as the geniohyoid and the genioglossus muscle. Below it is the digastric fossa, which serves as an attachment to the anterior half of the digastric muscle. Lateral to it is the sublingual and the submandibular fossa, which houses the two salivary glands of the respective names. Just above the submandibular fossa and lateral to it is the mylohyoid line, which gives rise to the attachment of the mylohyoid muscle, which forms the diaphragm of the oral floor. Lateral to it is the pterygoid tubercles, where the pterygoid muscles are attached. Above it is the mylohyoid groove, and above that is the lingula, which serves as a protecting structure for the mandibular foramen. Coming to development of mandible, we all know that Meckel's cartilage is closely associated with the mandible and the mandibular nerve, but the Meckel's cartilage does not directly form the mandible, because the mandible is formed by intramembranous ossification and not intracondylar ossification. As soon as the mandibular nerve is formed from the first brachial arch, it secretes certain chemotactic and chemotropic factors which causes hyalinization and cartilage formation around it, which forms the Meckel's cartilage. The Meckel's cartilage forms in the shape of the mandible, but unfortunately or fortunately, it has no almost nil role in forming the actual mandible. Rather, in around the 6th week of intrauterine life, the Meckel's cartilage gets mesenchymal thickenings around it, and this mesenchymal thickening is what gets ossified, that is intramembranous ossification. The Meckel's cartilage gets dissolved and resorbed into the body, and gradually the ossification continues on the intramembranous type. A single ossification center for each half of the mandible arises in the 6th week of the intrauterine life in the region of the bifurcation of the inferior alveolar nerve into the mental and incisive branches. So, anteriorly, where the inferior alveolar nerve branches out into the mental and incisive branches, there one ossification center for each half arises, from where the ossification spreads in a fan-like or a circular fashion. Ossification stops at the site which will later become the mandibular lingula, from where Meckel's cartilage continues into the middle ear and develops into the auditory ear cycles, that is malleus and incus, which are the only remaining structures of the that is formed from the Meckel's cartilage directly. Coming to muscle attachments, in the posteriormost region, the greatest area is covered by the attachment of the masseter muscle in the lateral surface or the external surface of the mandible in the ramus region. Just above it, on the coronoid process, comes the attachment of the superficial half of the temporalis muscle. Just anterior to it, near the molar area, near the anterior border of the mandible, is the attachment for the buccinator muscle. In the anteriormost region, there is the attachment for the mentalis muscle, the triangularis, and the platysma muscle as well. Coming to the inner surface of the mandible, the inner surface of the coronoid process gives rise to the attachment of the deeper layer of the temporalis muscle. The condylar neck gives rise to the attachment of the pterygus externa or the lateral pterygoid. The angle region of and a portion of the inner surface of the ramus gives rise to the attachment of the pterygoids internus or the medial pterygoid. The mylohyoid line gives rise to the mylohyoid or mylohyoid muscle, and the digastric fossa gives rise to the attachment of the anterior arm or anterior half of the digastric muscle. The genial tubercles, as you can see, gives rise to the attachment of the geniohyoid and the genioglossus. So, fractures. Fractures of the mandible occur more frequently than any other facial skeleton. According to a study by Orikainen and linguists in 1975, it comprises of 61% of all the craniofacial fractures. It is broadly divided into 1. Fractures with no gross comminution of the bone and without significant loss of hard and soft tissues, and number 2. Fractures with gross comminution of the bone and with extensive loss of both hard and soft tissues. Classification of fractures. It can be classified according to type of fracture, site of fracture, cause of fracture. Coming to type of fracture, it can be simple, which includes a closed linear fracture of the condyle, coronoid, ramus, edentulous body of mandible, parasymphysis or symphysis fracture. Compound fractures is fractures of tooth-bearing portions of mandible into the mouth via the periodontal membrane and at times through overlying skin. That is, compound fractures, we generally say it is open to the external environment because we consider the oral cavity as an external environment. Then, comminuted fracture is usually formed when there is not a single fracture line, rather there are multiple fracture lines resulting in multiple fracture segments. The last is pathological, which results from an already weakened mandible by pathological conditions such as osteoporosis or maybe resorbed mandible due to any tumor or any cyst. Now we see the pictorial representation of the simple, compound and comminuted fractures of the mandible. Now according to site of fracture, it can be dentoalveolar, condyle, coronoid, ramus, angle, body, parasymphysis and symphysis fracture. So here we have to understand that the symphysis area is between the two central incisors. Parasymphysis area comprises of the area between the lateral incisor and the premolars. The body comprises of the area which is between the premolar and the molar bearing areas. So a pictorial representation of the various areas where the fracture can happen. A can be condylar fracture, which can be either a condylar head fracture or a condylar neck fracture. B is a coronoid process fracture. C is a ramus fracture, which can be a horizontal or an oblique. Here we can see an horizontal or an oblique fracture can happen, or sometimes even a vertical fracture of the ramus can also happen. D is for angle fracture. E is for body fracture. F is for parasymphysis. G is for symphysis, and H is for dentoalveolar fracture. Dental alveolar fracture happens when a segment of the alveolus gets fractured along with the tooth that it houses. So there will be segmental mobility along with the tooth. So according to cause of fracture, it can be direct violence, indirect violence, and excessive muscular contraction. In case of direct violence, the fracture will happen at the point of application of the force or trauma, such as suppose a person gets punched in the right body of mandible region, and if the right body of mandible fractures or the right parasympathetic region fractures, then it will become a direct violence fracture. In case of indirect violence fracture, the fracture occurs far away from the point of application of the trauma or force. For example, similar case, if there is a trauma to the right side of the body of mandible, but the fracture occurs in the left neck or head of the condyle, then it will become an indirect violence fracture. In excessive muscular contraction, the fracture of coronal process generally happens due to a sudden reflex contracture of the temporalis muscle. Coming to etiology of mandibular fracture, it can be due to road traffic accidents, interpersonal violence, contact sports, industrial trauma, and falls. General signs and symptoms that we can see in mandibular fractures are swelling, pain, drooling of saliva, tenderness, bony discontinuity, lacerations of soft tissue, which can be either extraoral or intraoral, limitation in mouth opening, ecchymosis, fractured subluxed or luxated teeth, and bleeding from mouth. Coming to specific signs and symptoms according to the area of fracture. Dental fracture, it will cause lip bruises, laceration, step deformity, bony discontinuity, fracture, luxation or subluxation of tooth, laceration of the gingiva. Fracture of the body, there will be swelling, pain, tenderness, step deformity, anesthesia or paresthesia of the lip, intraoral hemorrhage. Anesthesia or paresthesia of the lip can be due to the infraalveolar nerve getting damaged. It can be completely severed or maybe a partial trauma can happen, which can cause either a transient or a permanent paresthesia of the lip. Symphyseal or parasymphyseal fractures, it can be tenderness, sublingual hematoma, loss of tongue control, soft tissue injury to the chin and lower lip. Loss of tongue control may be due to bilateral parasymphysis fracture, which will cause the entire segment to be displaced posteriorly, and as we know, the genioglossus muscle gets attachment to this region, so it can cause loss of control of tongue. Coming to fracture of ramus, there will be swelling, tenderness, ecchymosis, pain, and trismus. Trismus may be due to the fracture affecting the masseter muscle. It can be due to entrapment of the masseter muscle, or it can be due to severing or tearing of the masseter muscle, or it can be due to the inflammation as well, which can cause a muscle spasm. Fracture of the angle, there will be swelling, posterior gap, deranged occlusion, anesthesia, paresthesia of lower lip, hematoma, step deformity behind the last molar, and tenderness. We have to see that step deformity most of the time can be palpated by finger itself. Anesthesia or paresthesia of the lower lip is due to the same reason, that is the infraalveolar nerve getting defected. Deranged occlusion may be due to the superior and inferior displacement of the segment. Coronal fracture, there will be tenderness over the anterior part of the tragus. Hematoma, painful limitation of movement, protrusion of mandible may be present. Painful limitation of movement can be due to the displacement and cross displacement generally, and deflection of the coronal process into the temporalis fossa in just behind the zygomatic arch, which will hinder in the movement of the mandible. Symphyseal or parasymphyseal fractures, tenderness, pain, step deformity, sublingual hematoma, loss of tongue control, may have soft tissue injury and chin or lower lip. Condylar fracture, it can be unilateral or bilateral, and it can be intracapsular or extracapsular. In unilateral condylar fractures, there will be swelling over the TMJ, hemorrhage from the ear on the affected side, battle sign, locked mandible, hollow over the condylar region after edema has subsided, and rarely paresthesia of lower lip, deviation to the affected side upon opening, painful limitation of movement. So, battle sign is a hemorrhage that can be seen or a subcutaneous hemorrhage that can be seen in the posterior auricular region. It can be due to the bleeding from the TMJ region getting pooled in the loose alveolar tissue just behind the ear. Hemorrhage from the ear on the affected side can be due to the condylar head traumatizing the glenoid fossa, rupturing it and rupturing through the external auditory canal and thus severing blood vessels. Bilateral condylar fracture, all the same symptoms will be there along with limitation in mouth opening, restricted mandibular movement and anterior open bite. So coming to examination, digital palpation and visualization is of paramount importance and will eventually guide in proper diagnosis of what kind of fracture has happened, and this can also be augmented with radiographic investigations. The various radiographic investigations that we generally use are OPG, that is orthopantomogram, X-ray, PNS view, reverse Downey's view, which will show us the condylar process, skull PA view, CT facial goes with the 3D reconstruction, which is the latest that we generally use for proper diagnosis. As you can see in the upper right hand corner is a 3D reconstruction of the facial bones, where you can see an angle fracture of the right hand side and as well as the symphysis fracture. In a lower left corner we see an OPG which shows right hand side parasymphysis fracture, and in the lower right hand corner we see a reverse Downey's view where we can see a clear picture of a right hand side condylar neck fracture. This is another set of photos showing symphysis and parasymphysis fracture in 3D reconstruction, various views. The first is a transverse view and the other two are 3D reconstruction views. Management. The management of mandibular trauma cases is the same as management of in most of the other trauma cases. That is, we need to follow ABCDE, that is airway, breathing, circulation, disability and exposure. In airway, we have to check for airway blockage if it is getting blocked by any foreign debris or vomit or blood or fracture segment or tongue fallback. While we are seeing this, we also have to negate or we have to eliminate cervical spine injury. If the patient is conscious and patient is saying tenderness in the cervical region, we have to immediately stabilize the head with head blocks and send for a cervical spine X-ray to eliminate cervical spine injury. If the patient is unconscious, we have to assume the worst and stabilize the head and do an X-ray. We have to do this so that we can see if there is cervical spine injury, because if there is cervical spine injury and if we are not careful, it can cause a permanent lower half body paralysis. Breathing, we have to check for tension pneumothorax, pulmonary edema, bronchospasm, as well as paroxysmal breathing, abdominal breathing, pain while breathing, rate of breathing, all these things. Circulation, we have to check for patients going into shock, which can be hypovolemic, obstructive, disruptive and cardiogenic. We have to see if there is immense hematoma or hemorrhage happening. We have to manage those accordingly. Disability, it can be seizure, hypoglycemia, meningitis, intracranial hemorrhage or infarction and intoxication. These all can hinder in the proper management and can cause severe morbidity in the patients. Exposure, hypothermia, hyperthermia, critical skin condition, stress fasciitis or urticaria are all important factors which determine the survivability of the patient and the morbidity and prognosis of the case. Other than ABCDE, we also have to check for soft tissue lacerations, and if it is there, we have to suture it to control bleeding and prevent a pathway for the germs to enter the system. Support of bone fragments has to be done, pain control has to be done. Pain control is very important because while there is immense pain, the patient will not be stable. The vitals will always be elevated. So proper analgesic use is of paramount importance. Infection control, example in case of compound fractures, food and fluid through IV and Ryle's tube. Coming to definitive treatment, the treatment plan is as follows. There are three phases which can be combined or it can be individualistic as well: reduction, immobilization and fixation. In reduction, it is the restoration of functional element of the bone fragments using occlusion. It can be open reduction, it can be closed reduction. Immobilization is to allow bone healing, and fixation is through fixation of the fracture line. It can be rigid or non-rigid. Now, before we go into the depth of these different treatments, we have to understand a concept which is teeth in line of fracture and its removal or management. Teeth in line of fracture are potential impediment to healing because of the following reasons. One, the fracture is compounded into the mouth via the open periodontal membrane, which can cause an entry of various pathological microorganisms. The tooth may be damaged structurally or lose its blood supply, may be cut off as a result of trauma, so that the pulp subsequently becomes necrotic, and thus necrotic and inflammatory agents may leak into the surrounding tissues, causing delayed healing or improper healing of the bone segments. The tooth may be infected by some pre-existing pathological process, which can also hinder the healing. Indications of removal of teeth in line of fracture are absolute and relative. Absolute indications are longitudinal fracture involving the root, dislocation or subluxation of tooth from socket, presence of periapical infection, infected fracture line, acute pericoronitis. Relative indications can be functionless tooth which would be eventually removed electively, advanced caries, advanced periodontal disease, teeth involved in untreated fractures present more than 3 days after injury. Coming to reduction, it can be closed reduction, where fracture reduction that involves techniques of not opening the skin or mucosa covering the fracture site. We do not give an incision in closed reduction. Fracture site heals by secondary bone healing. This is also a form of non-rigid fixation. The indications for closed reduction are non-displaced peripheral fractures, mandibular fractures in children with developing dentition, condylar fractures. In developing dentition and in children, we generally go for closed reduction because it can cause adverse effects such as growth deformities, or it can sometimes children may not be strong enough to undergo major open surgery. Contraindications are alcoholic, seizure disorder, mental retardation, nutritional concerns, respiratory distress such as chronic obstructive pulmonary disease, unfavorable fractures. In these cases, open reduction is always preferred. Advantages of closed reduction is low cost, short procedure time, can be done in clinical setting with local anesthesia or sedation, easy procedure. Disadvantages are not absolute stability, secondary bone healing, oral hygiene is very difficult to maintain, possible TMJ disorder can happen, muscular atrophy or stiffness can happen, decreased range of motion can also be a very problematic side effect. In case of open reduction, it implies the opening of skin or mucosa to visualize the fracture and thus reduction of the fracture. As you can see in the photo, there is an incision has been given and the fracture site has been exposed for reduction. It can be used for manipulation of fracture only. It can also be used for non-rigid or rigid fixation of the fracture. Indications are unfavorable or unstable mandibular fractures, fractures of an edentulous mandible fracture with severe displacement, this delayed treatment with interposition of soft tissues that prevents closed reduction, that is, soft tissue has become ingrown into the fracture site, and thus a reapproximation will be difficult. In case of cases needing internal fixation, also open reduction is needed. Contraindication is in patients with severe systematic conditions and morbidity such as hemophilia or severely old patients with very weak and frail bodies. Immobilization, it is a simple guide to time of immobilization for fractures of tooth bearing area of mandible is as follows. Young adults with fracture of angle receiving early treatment in which tooth removed from fracture line will be 3 weeks. If tooth retained in fracture line, there will be 1 week will be added. Fracture at symphysis, 1 week will be added. Age 40 years and above, 1 week or 2 weeks may be added. Children and adolescent 1 week may be subtracted. This immobilization, it can be done through MMF, that is maxillomandibular fixation. The various techniques that are used are arch bars, that is Eric arch bars, IV loops, NSIC wires, intermaxillary fixation, which is now known as maxillomandibular fixation, splints, bridle wires. So as you can see, the topmost right hand side is the Eric arch bars, the lower left hand side is intermaxillary fixation screws, and the last one is bridle wiring. Coming to fixation, it is osteosynthesis, and it can be osteosynthesis without intermaxillary fixation, uh, which is non-compression small plates, compression plates, mini plates, and lag screws. Intermaxillary fixation with osteosynthesis can be transosseous wiring, circumferential wiring in external pin fixation, bone clamps, transfixation with culture wires. Intermaxillary fixation on its own can be bonded brackets, dental wiring, direct wiring, allied wiring, arch bars, and cap splints. Coming to Champe's principles, these are principles which are devised by Champe for proper fixation. Forces of mastication produce tensional forces on upper border and forces of compression on the lower border. Champe put forward the lines where plates and screws have to be placed, that is for ideal osteosynthesis. It corresponds to the force of a line of tension at a base of the alveolar process. And now, principles of fixation. Usually one plate with 4 cortices for fixation are required for adequate immobilization, that is 4 screws. Anterior to mental foramen, 2 levels of fixation are required to overcome torsional forces. Unfavorable fractures usually require 2 levels of fixation for stability. Fixation along Champe's lines allows better fixation due to strong buttress structure, that is strong cortical bone. Management of according to various position. Management of mandibular angle fracture, one of the most common fracture sites. Non-displaced fractures can be treated with MMF for 6 weeks. Reasons are presence of impacted third molar, thinner cross section in the area of angle, biomechanical labor arm, and also one more reason is the chance of damage to the facial nerves. Although maintenance of absolute rigidity on treatment of angle fracture has been a major principle, in 1973, Minchelet et al. Described the use of small malleable bone plates for treatment of angle fracture. This is in open reduction fixation only. This led to the change from previous belief that rigid fixation was necessary for bone healing. Later, Champe et al. Validated this technique by performing several clinical investigations. They determined that the most stable location where the bone plate should be placed based on Champe's ideal lines of osteosynthesis. Disadvantage is unable for close reduction is unable to achieve absolute immobilization. Thus, a prospective study performed by Amrish Bagol et al. Found out that extraoral ORIF, that is open reduction internal fixation with a reconstruction plate, and internal ORIF using a single mini plate has the least complication and the best results for management of angular fracture. Management of coronary process and ramus fracture. Most ramus fractures can be treated with MMF for 6 weeks, but the challenges are difficult intraoral plating. External approaches for plating is similar to the angle, but there is the same chance of damage of the facial nerves. Coronary fracture is uncommon and is generally occurring with a zygomatico complex fracture. Management of condylar fracture. Most condylar fractures can be treated with MMF for 2 to 4 weeks. If head is involved, MMF is limited to 2 weeks to prevent TMJ ankylosing. Frequent scenario in a condylar fracture with contralateral parasympachial body or angle fracture is the treatment of contralateral fracture with ORIF and condylar fracture with MMF for 2 to 4 weeks. When plating is required, an external approach is preferred, but it can cause damage to the facial nerve, so facial nerve preservation is of paramount importance. External approach is similar to the angle approach, but with superior end of the incision brought to about 2 cm from the earlobe. Controversial treatment options between closed and open reduction is always there. Treatment aim is always to recover normal TMJ function. Treatment choice depends on the fracture level, amount of displacement, adequacy of the occlusion, and age. So, in open reduction, the advantages are early mobilization of the mandible, better occlusal results, better function, maintenance of posterior ramal height, avoidance of facial asymmetries. Disadvantages are risk of damage to facial nerve branch and chance of cutaneous scar. Closed reduction includes MMF with elastics. Degree of displacement of the condylar fracture has been used in deciding between open or closed reduction. McNaughton et al. Recommended open reduction if the condylar displacement was greater than 45 degree. Widmark told if it was greater than 30 degree. Zaid and Kent described the absolute and relative indications for open reduction of condylar fractures. The absolute indications are displacement of condylar head into the middle cranial fossa, impossibility of obtaining adequate occlusion by closed reduction, lateral extracapsular displacement of the condyle, and invasion of foreign material, that is suppose in case of a gunshot wound. Relative indications can be bilateral condylar fractures in edentulous patients, unilateral or bilateral condylar fractures when splinting is not recommended for medical reasons, bilateral condylar fractures associated with comminuted midface fractures because at that time MMF is impossible, bilateral condylar fractures and associated anthological problems, that is lack of posterior occlusal support. Coming to management of fracture body of mandible. Simple fractures involving the body of mandible can be effectively treated with one mini plate along the Champi line of osteosynthesis near the anterior border of the mandible. Dissection should be done avoiding the damage to mental nerve as well as facial nerve, which supplies the lower lip. Champi popularized the treatment of mandibular fractures with mini plate fixation along the ideal lines of osteosynthesis. This is a form of load-sharing osteosynthesis to be applied in simple fracture patterns having an acceptable amount of bone stock. It is generally an intraoral approach, which is the best course of treatment. Arch bars are placed and MM wires are secured prior to incision for maximum stability and immobilization. 5 cm incision is made in the gingival sulcus over the fracture, leaving 1 cm cup of tissue from the mucogingival junction for closure. Dissection is carried to the bone, that is a full mucopedestal flap is reflected. Mental nerves are identified and preserved. Fracture line is debrided, reduced, and MMF is tightened. 4-hole tension bands secured between the tooth roots and metal foramen with monocortical screws. Larger 2.3 to 2.7 system titanium plate is secured anteriorly through the intraoral incision with 2 to 3 screws. MMF wires are cut and occlusal is checked. If it is satisfactory, then incision is closed. Coming to management of fracture, parasymphysis and symphysis fracture. Parasymphysial fractures, fracture lines, what happens is we need 2 plates for the proper securing of the fracture lines because there will be torsional forces. Several authors have shown that mini plate fixation in symphysis and parasymphysis fracture is very effective in fixing the fractures. Most common approaches transoral gingivolabial and gingivobuccal incisions. Larger comminuted fractures and external approach sometimes may be necessary to accurately and rigidly fixate the mandible. Simple symphysis fractures can be treated with 2 mini plates fixation, as I told earlier. Single mini plates are not given because there can be displacement due to torsional forces. One mini plate is placed in the inferior border and the second plate is placed superiorly. Several authors have shown mini plate fixation along with lines of Champi is very effective in fixating these fractures. More rigid fixation should be considered for comminuted fractures. Lap screws can be used, and if used is in reduction of lingual border of the fracture and re-establish the appropriate intergonial distance by squeezing the mandibular angles together for optimal strength. 2 lag screws can be used. Coming to special considerations, edentulous mandible and mandible in children. Mandibular fractures in children generally is of green stick type, that is, complete fracture does not happen generally due to resilience of the mandible. Mandible is resilient in this period. Line between the cortex and mandible is very less well defined. High ratio of bone to teeth substance is there. Factors to consider in treating fractures in children are interference with bone growth potential, fixation in deciduous mixed dentition, and undirected tooth. Generally, we prefer not to use plating and screwing because it can cause developmental anomalies because the bone is still growing. We generally go for an MMF. Now coming to fracture of edentulous mandible, influencing factors are decrease in inferior alveolar artery supply, that is centrifugal blood flow, dependent on periosteal, that is centripetal blood flow. Thus, there can be ischemia and bone healing can be disrupted. Medical conditions that delay healing, such as diabetes mellitus, decreased ability to heal with age, altered physical characteristics following tooth loss, that is resorption of the alveolar process. The methods used in immobilization in such cases are direct osteosynthesis, bone plates, transosseous wiring, circumferential wiring. Indirect skeletal fixation can be pin fixation, bone clamps. Intermaxillary fixation using gunning type springs can also be used. It can be used alone or it can be combined with the aforementioned techniques. So one special condition over here is in case of bilateral condylar fracture in completely lingulous mandibles, it is known as a bucket handle fracture. It is a very dangerous condition because it can cause an airway obstruction and so management is of paramount importance. Complications in mandibular fracture management is there can be misapplied fixation, there can be infection of the plate, TMJ ankylosis can happen, nerve damage can be happen, displaced tooth can be there, gingival and periodontal complications, malnutrition due to MMF, delayed union or non-union, inadequate immobilization leading to fracture disalignment. Interposition of soft tissue or foreign body in incorrect technique, limitation in mouth opening and scar formation. Coming to recent developments in mandibular fracture management, the use of 3D navigation system in mandibular fracture treatment as described by Matthias Witcher et al. In 2001 is of very usefulness to us nowadays. Recently, endoscopic subcondylar fracture repair has been described with encouraging results. We have also come across the Herbert bone screw, which may replace the mini plates or compression plates at some point in the future. Thank you. I hope you have learned a bit about mandibular fracture and its management through this sequence of slides. And now I would like to end the session. Thank you so much.